Hello, my name is Jackie Orenda-Weber. The title of my capstone poster is Developing Evidence-Based and Occupation-Centered Best Practice Guidelines for the Treatment of Visual Dysfunction and Visual Impairment Post-Acquired Brain Injury in a Hospital Setting. I've been fascinated with vision and visual information processing for many years, well before OT school actually, and I was ecstatic about this opportunity to combine my passions. I'd like to walk you through my poster via slides today, starting with the background. First, a note about terminology. In my capstone, I used terms proposed by the conceptual model for vision rehabilitation. Visual dysfunction describes deficits in higher order cerebral mechanisms that impact how a person functions. And the term visual impairment describes deficits in how the eye, as an organ, and lower order cerebral mechanisms function. As vision is classified as a body function, the visual system is within the occupational therapy scope of practice. Occupational therapy practitioners, or OTPs, may provide vision interventions to improve occupational performance. As many as 90% of acquired brain injury survivors experience visual symptoms following the event. Due to acutely impaired cognition or aphasia, nearly half of stroke survivors with visual dysfunction do not or cannot report symptoms, though. A study of over 1,000 occupational therapy practitioners across 4 states revealed that less than 1/3 of them regularly screened for brain injury-related vision dysfunction. Furthermore, patients with visual impairment who are hospitalized for reasons unrelated to vision experience longer lengths of stay, higher readmission rates, and higher costs during hospitalization and 90 days after discharge. Responsibility for screening vision and determining vision-related treatment plans typically falls on occupational therapists, but several nationwide studies found that OT practitioners feel unprepared to interpret screening results or provide vision-related interventions. Clearly, opportunities exist to improve patient care and reduce costs by addressing visual dysfunction and visual impairment within hospitals. I completed my capstone experience at Salem Hospital, which is a primary stroke center and one of the largest acute care hospitals in Oregon. Last year, nearly 2/3 of the patients admitted to inpatient rehabilitation had some kind of brain injury diagnosis. The fundamental purpose of my capstone was to improve outcomes for patients with vision problems. And in working toward that purpose, my objective was to augment occupational therapy practitioners' toolkit for addressing visual dysfunction and visual impairment among patients with an ABI or acquired brain injury at Salem Hospital. During my capstone, there were 3 theories that guided my work. First is the Person-Environment-Occupation, or PEO, model. This occupation-based model helped ground my work in the principles of occupational therapy. In my capstone work, I applied this model by viewing Salem Hospital OTPs collectively as the person, Salem Hospital as the environment, and the job of providing occupational therapy services as the occupation. I aimed to find the best fit among these 3 components with my interventions to maximize occupational performance, which ultimately contributes to my purpose of improving patient outcomes. This diagram shows that the Interprofessional Education Collaborative, or IPEC, core competencies are both patient and family-centered and community and population-oriented. The IPEC core competencies include interprofessional teamwork and team-based practice, interprofessional communication practices, roles and responsibilities for collaborative practice, and values ethics for interprofessional practice. These core competencies have repeatedly been found to contribute to successful interprofessional collaborative practice. Because patients with visual dysfunction and visual impairment interact with numerous professionals of various disciplines during their recovery, it was critical that I consider how to foster effective interprofessional communication and interprofessional collaboration at the hospital. And lastly, a conceptual model for vision rehabilitation. This model offers well-defined role delineation between vision specialists and OTPs and a framework for collaboration. The diagram shown here depicts the signs and symptoms that initiate a referral to vision specialists and non-vision specialists, as well as the referrals from one to the other. Vision specialists treat the impairment of body structures. Non-vision specialists primarily treat the impairment of body functions, which may impact activities of daily living, learning, communication, and applied knowledge, mobility, and interpersonal interactions and relations. All of these providers contribute their expertise to create interventions that improve quality of life as well as functional vision. My capstone process started with an evaluation. I observed OT sessions. I sent out a survey to all Salem Hospital-based OTPs. I conducted a focus group with Salem Hospital-based OTPs, and I interviewed team members from other disciplines. From this needs assessment, I identified that vision-related practice patterns vary among OTPs at Salem Hospital. OTPs want to use standardized, formal, objective vision assessments, but they didn't have any available to them. There was some confusion about where to refer clients with visual concerns. And in general, OTPs expressed low confidence to treat vision and to communicate about vision in writing. I designed interventions to meet these needs, including an evidence-based best practice guideline for the treatment of visual dysfunction and visual impairment, an interprofessional care pathway, a list of vision specialists and instructions for referral, and training sessions for vision assessments and interventions. I developed best practice guidelines, an interprofessional care pathway, a vision specialist referral list, and a series of 4 training sessions for OTPs. As I dug into the literature to learn about vision treatment, my definition for best practice required that interventions and assessments be evidence-based, occupation-centered, efficient for application in the hospital, and sustainable to be replicated across multiple sessions and various therapists. OTPs appreciated the evidence-based assessments and interventions included in the best practice guideline. Some of these were familiar, but OTPs maybe didn't realize they were so well supported by research, and others were brand new and exciting. The interprofessional care pathway is meant to begin at the emergency department and ABI diagnosis and extend through the neurotrauma care unit, inpatient rehabilitation, and out into the community. Although I wasn't able to meet with all of the providers necessary to complete this deliverable, I made progress in charting a patient's route through care, filling the gaps and answering questions about who does what and when, and I made recommendations for continued improvement. I designed a series of 4 training sessions that taught OTPs about all aspects of vision, from anatomy and neurology to functional implications. OTPs noted that the strengths of the training sessions included clear explanations of various visual conditions and step-by-step instructions for how to evaluate and assess vision. The percentage of OTPs who agreed with the statement, "I feel adequately prepared to undertake a visual dysfunction, visual impairment caseload," increased by 50% after the training sessions. I don't have time to go through the full best practice guidelines that I developed, but I would like to share a couple of examples to help make the work a little more concrete for listeners. Supported by extensive research, I developed a standardized vision screening comprised of evidence-based assessments and skilled observations of 9 components of vision. These include a case history, observations, distance acuity, reading, eye movements, eye alignment, visual fields, visuospatial neglect, and functional observations. Prior to my capstone, the hospital lacked a standardized vision screening. OTPs utilized a mixture of methods, which limited the ability to communicate results to others. Now, Salem Hospital OTPs have a set of formal assessments with clear scoring criteria and documentation wording. One intervention example is scanning techniques for visual field deficits. Prior to my capstone, OTPs emphasized the lighthouse method of scanning, in which a person turns their head from shoulder to shoulder to view their environment. And I found that while head movements are useful for larger gaze shifts, accurate scanning with eye movements is key to safety for these patients with visual field deficits. So I taught OTPs a scanning technique and explained how it can be utilized in the context of occupation to supplement rather than take over their daily sessions with patients. The key implication here is that hospital councils may implement protocols for the standardization of vision care for the purpose of improving patient outcomes. During my capstone experience and project, I learned that conducting a thorough needs assessment that includes the voices of OTPs and interprofessional team members is time-consuming. It's going to uncover differing perspectives, but it's also ultimately going to facilitate widespread endorsement of the project. I learned the importance of considering the context of the work environment and the limited time available for OTPs to attend optional meetings. I learned that while OTPs found the content of the training sessions very valuable, saving space for them to discuss vision treatment and implications amongst their peers was equally important. Lastly, I learned that interventions don't need to be complex to make a difference. The conversations I had with vision specialists and shared with OTPs boosted their confidence and gave them referral sources immediately. Once the occupational therapy best practice guidelines for vision are in place, the work is not done. I highly recommend that the guidelines be extended to all disciplines and settings within the hospital, including the emergency department, ICU, and inpatient rehab. These guidelines should be developed with interprofessional input to ensure a positive patient experience along a smooth care pathway. I recommend that representatives from each discipline and setting meet annually to review and update the guidelines to ensure they still represent the best practice in light of any new evidence. Lastly, I recommend that OTPs engage regularly in vision-related skill building with case studies that involve the care pathway and that emphasize those interprofessional core competencies. I'd like to offer a special thanks to my capstone advisor, Elisa Jordan-Sheth, my capstone site mentor, James Dobkins, and my incredibly supportive husband, Justin Weber. And thank you so much for listening. I hope this presentation has been informative or maybe even inspirational. I encourage you to scan this QR code in the lower right-hand corner to view references for this presentation, as well as for the full capstone project, and my contact information and a selection of materials that I created during the experience. Thank you.